series discussion on the Breast Cancer Awareness Month that we are in. As 21st October is the Breast Cancer Action Day, being recognized by Integrated Health and Wellbeing Council. This initiative is an initiative of IHW Council along with Rapid Global Cancer Alliance and is being powered by Novartis. The discussion for today is on the very pertinent topic of unveiling the breast cancer landscape in India. And we are being joined by very eminent panelists for this discussion. Allow me to welcome our esteemed set of panelists. We would be joined by Dr. Ashok Kumar Vaid, who is Chairman of Medical Hematology Oncology Cancer Institute, Medanta. We will be joined by Dr. S.V.S. Deo, who is Professor and Head of Dr. BRAIRCH, New Delhi, and National Cancer Institute, AIMS, Jahar, and Head of Delhi Cancer Registry. We would also be joined by Dr. Sushma Bhatnagar, Chief of Dr. BRAIRCH of AIMS. And we have Dr. Sushmita Rath here with us today, who is the Consultant Medical Oncologist at Tata Memorial Center. So, ma'am, thank you so much for joining. Let us start our discussion on the very pertinent topic of breast cancer. So, as we know, breast cancer is on the rise in the recent years that the studies have suggested. And we would like to know more about how the breast cancer landscape in India is. So the first question that we would like to know from you is on, as you represent a leading institution being a medical oncologist, what do you feel about the current prevalence and incidence rates of breast cancer in India? And what do you feel are the factors that have contributed it to such rise in the recent times?
Yeah, very good morning, all of you. Is it audible? Can you hear me?
Yes, ma'am, please go on.
Yeah. So I would like to just say that at the outset, we know that breast cancer has been one of the most common cancers among all the women in India, globally also. And what basically I would like to say is when you move back 10 years behind, when you went back to 1990s, breast cancer was one of the fourth most common cancer. But currently, since 2016, we have seen that breast cancer is actually the number one cancer among women. And if we were to just tell you some basic numbers, so the age adjusted incidence rate is about 25 per 100,000 women, and the chance of dying, or so to say mortality, is basically that 12.7 per 100,000 women. So this situation is so alarming that the breast cancer incidence is rising. And if I were to just tell you in terms of percentages, if you were to follow the percentage, then it is also important to note that breast cancer currently accounts to around 13% of all the common cancers and 10% of cancer deaths in women. So this is currently the state of affairs. And I would like to say that we are also aware that what basically happens is when you present when the lady comes to us with an advanced stage, the chances of survival up to 5 years decreases. So as we see, when we see the first stage, the chance of surviving up to 5 years is around 90%. When you go down to the third stage, it comes down to 70%. And we know that fourth stage is when the breast cancer actually leaves the breast and spreads to different parts of the body. And that is when the 5-year survival comes down to around 10 to 20% only. So the situation is very alarming. There's some basic observations from low middle income countries, and from our countries. Basically, what happens is most of our patients or women who present with breast cancer, they stay in rural areas. We know that rural areas 70% of women are there, but all the medical oncologist, surgery, radiation infrastructure, everything, the cancer infrastructure, 95% of that is present in the urban areas. And if you see the important problems, the first and foremost is delay in seeking health care. If you see a common lady, when she presents with a breast lump, and if it is not causing any pain, because the cancer lump is mostly painless, So if it is not causing pain, the lady actually tries to ignore, because they're so busy in household activities, they ignore, and finally when they come to the doctor, when the symptoms become unbearable, it is mostly found in the third stage. So 60% of our ladies actually come in the third stage. They have a breast lump, and they also have a involvement in the armpit. Even armpit, there is a lymph node, or there is a growth in the armpit also, that makes it a locally advanced stage. So this is the state of affairs. The first most important problem related to current times in Indian country or in low middle income countries, delay in seeking healthcare. Number one. Number two is, again, I would like to say that the breast cancer treatment is not cheap, because as you know that breast cancer treatment does not only include an operation or surgical removal of the tumor. You also have to give radiation, you also have to take IV chemotherapy, IV medicines, and you also have to take tablets. So all these combined, now this leads to a big out of pocket expenditure for a middle class family. I mean, for a family to afford all the treatment, it becomes an out of pocket expenditure. So I thought these are some of the points. And if you ask me what can be done in current times, I would strongly suggest, we also have a paper from Mumbai. There was a publication, an article, that only by doing a screening as in only by performing, the lady can actually only do a self breast examination. You have to only examine yourself while taking bath, and if you do that examination yourself or by a healthcare provider in any of the primary healthcare hospital or a secondary hospital, any hospital, if you do only a self exam, you are able to reduce the detection of third stage or advanced stage by actually 15 to 20%. So it is very important for all our women to do a breast self exam. And if it's, as we know that now all the centers, all the two tier cities also have a mammogram facility, wherein a mammogram can be performed. It's a low X-ray of both the breast, which can actually rule out any suspicious cancerous lumps or masses. So anyway, so self examination should be done, and timely reporting to healthcare providers should be done. So like these factors that I would like to highlight. So Asawari, you can just ask some leading questions. I mean, what do you want to know in this? I mean, what else we can add to the discussion?
Yes, ma'am. I believe
You want to add something?
I believe we have some little network issue from your end, but we were able to understand what you said even at the end. So, ma'am, as we are talking about the breast cancer landscape, and as rightly pointed out by you, most of the women that you shared, that are coming from rural backgrounds, and the infrastructure for breast cancer care and all the technologies are more readily available in the urban space. So, how do you feel, this discrepancy in the distribution of accessibility and availability of breast cancer care can be bridged? What initiatives can be taken up? Or if you can, highlight some of the advances that you have seen in your practice, that these all therapies and testing methods are now being brought to the rural health facilities as well? Or do you feel that there is still some time, for that, for us to achieve that, and it is a far-fetched goal? What are the real scenarios in your experience?
No, so there are a couple of points I would like to add. One is definitely, I told that various screening programs, or at least healthcare providers can actually have, they can give screening programs, and camps can be held in various rural areas wherein healthcare providers can go and do the clinical examination. Number one. Number two is, there are certain steps which we also have taken in our institute. Is it audible? Because I'm not sure of the connection problem. Yeah. So I was just thinking, is it audible? Hello, is it audible?
Yes, ma'am, please go on.
Yeah. So I was saying that in our hospital, in Tata Hospital, especially in the times of COVID times and other this thing, so we had actually initiated the facility of a teleconsult. That is, we are still giving opinions on the phone and WhatsApp calls to patients who have getting treated for breast cancer management outside. So we have initiated the facility for teleconsultation. Number one is, I would like to highlight that telephonic services and WhatsApp video calls are being done by us for whomever who are taking treatment outside, or they have some doubts, they have been diagnosed with breast cancer, they need to know what line of management can be done in their case. So we are already doing a teleconsultation. Screening programs can be initiated in rural areas, so that at least a healthcare provider can do a clinical examination for the women that I told earlier. Apart from that, we need to increase the facility. I mean, lack of infrastructure and machines, all that have to be seen by the government. It's also important to highlight that there are several now government health agencies which are also giving free treatment. Like, if you know breast cancer, which is HER2 positive, because breast cancer has three receptor on it: hormone receptor and a HER2 receptor. So as we know that treatment which are directed towards or anti-HER2 directed therapy, they are very costly. They are actually targeted therapies. But now, because of the help from the Ministry of Health Welfare, and also because of the rural government schemes like from Rajiv Gandhi and Mahatma Phule schemes, this trastuzumab, or the anti-HER2 medicine, that is now become a bit more affordable for the women who are taking treatment in a government setup. So more and more, public health programs should come, and funding should be available. Like I told you, Ministry of Honorable Ministry of Health and Family Welfare is already funding treatment for breast cancers and gynecological cancers, and that has led to the treatment, like I told you, HER2 directed therapy and other medicines, basic chemotherapy medicines, which have now become cheaper and they are more affordable by the common population. So that can be done. Government schemes are, we can give our opinions on video, and then we can also have screening campaigns. All that can be done to increase the making the healthcare. I mean, making the access to the breast cancer healthcare better. So those are some of the points which I thought could be done.
Thank you so much, ma'am. Thank you for so nicely explaining all these aspects. So yes, as clearly you mentioned that the government initiatives are also very much helping in providing accessibility and equity for breast cancer care amongst rural areas in India as well. And of course, in the urban areas, we have specialized and modern treatments and all different advances in breast cancer care available. But ma'am, this breast cancer, word for any women is just like a big shock whenever they hear it, and nobody anticipates themselves to ever acquire breast cancer in their lifetimes. Nobody would want to wish that. So most of the people in India also still do not plan for such emergencies, medical emergencies. So how do you feel the integration with health insurance providers, not just for urban educated people, urban educated women, but also for rural women, if there are some provisions of providing health insurance so that they can go forward with their treatment, and also get supported from the government side in monetary ways, or from health insurance perspectives. How do you feel this is there, if you see this very well being accessed in your practice, or do you feel that amongst rural women this health insurance aspect is still not quite there? What do you feel?
I think the health insurance aspect is still not there. If you see patients being working in a tertiary care center, most of our patients are actually credit patients. So they get basically funding from their company, like, BRC, Central Government Health Scheme, from power companies, and all those by railway. Most of our also patients from railway credit patients who are getting treatment from the railways. All that is there. So we have different institutions already helping them. And I think the health insurance is still not come up well in our part of the country. I think health insurance schemes have to come up more. Though we don't have direct, so either we have a paying capacity patients, private patients who can pay for their treatment, they don't have any financial problems, or we have the general, this problem happens with the non-paying patients or the non-chargeable patients who are not able to pay for their treatment. For them, like I told you, we have government health schemes. Already Ministry of Health Welfare is kindly helping us with the treatment. Apart from that, Ayushman Bharat has helped us a lot. Ayushman Bharat schemes, Mahatma Phule schemes, these are there. But health insurance has to come up. There's not been much contribution from the health insurance schemes.
Thank you so much, ma'am. And definitely we will discuss more with the, appropriate representatives that would be joining us for the future episodes of this Breast Cancer Action Month series that we are in. There are a few other aspects that we would like to know more on, which is what are the prevailing, risk factors that you feel are most common, and do these risk factors differ from urban women to rural women drastically, or do you feel when in regard to breast cancer, these risk factors are all common for both urban and rural women?
So the risk factors, risk factors are basically common. There's no specific risk factor for rural and urban women. But I thought, if you go to, there's no modifiable risk factors like, a higher age at first childbirth, late age of getting the period, all these are some of the risk factors. It's important to be genetic counseling. Young ladies with family history of cancer.
Ma'am, we are not able to hear you very well. I believe there is some network issue on your end. Yes. Ma'am, we are not able to hear you. I believe there is some network issue. We are being joined by Dr. Ashok Kumar Ved, who is the chairman of Medical and Hemato-Oncology for Cancer Institute for Medanta. Sir, welcome to the show. Thank you so much for joining. Until we have the network issue of Dr. Sushmita ma'am sorted, I have a very pertinent question for you. So we are discussing the topic of unveiling the breast cancer landscape in India and looking at different aspects of how breast cancer range in different parts of the country and how the current situation is. So can you please share some insights on the diversity of, that you see in breast cancer prevalence in the country, and also the diversity in the healthcare accessibility across the country, and how these two do you feel if they are working together, or so that we can ensure that all segments of the population have access to high quality breast cancer care? What do you feel about this aspect? Over to you, sir.
Is that for me?
Yes, sir, for you.
Okay, so
should I repeat the question?
No, I got it.
Yes.
So good morning, namaste to everyone, and thanks a lot for making me a part of the proceeding this morning in this very prestigious and very important meeting, which is dwelling on the subjects of day-to-day practical importance, I must say. And congratulations to you for organizing such a good meeting. Now, first question first, the diversity and what has happened over the last 20, 25 years or 30 years. So in the 90s and till about the early part of the first decade of this century, we knew that cervical cancer was the #1 cancer. And there was a rural predilection, and that was the one which was driving the numbers. But over the last about 20, 25 years, the rapid urbanization, the rural urban migration, more women picking up jobs, late pregnancies, and so on and so forth, dietary changes and all that, has led to a boom, in fact, a proliferation of the breast cancer. And now it is #1 as far as the cancer in women is concerned. So we understand, we know that breast cancer has become #1. There may still be a rural sort of a predilection for a cervical cancer, but then the overall statistics is stacked in favor of breast cancer. So that's one part. And we know that younger women in India are actually getting affected. And if we look at the demographics globally, it's about 10% who would be young or very young, below the age of 35 years. That's technically what is called as very young. But in India, we are finding that women in their 30s, late 30s, are getting affected, and that's a very disturbing trend which we are encountering. So the long and short of it is that breast cancer is number one cancer, and the other side of the coin is that this is a cancer which is amenable to screening, but sadly we don't have the infrastructure to screen every woman above a certain age when the screening would actually apply. The second question that the accessibility and the healthcare spread out throughout the country. Now, I already made a mention about the lack of screening facilities and accessibility. Whatever screening we are doing is not a structured screening. We are only doing a very, very sort of opportunistic screening. Any lady who comes into the hospital or any family members of the patients who have been diagnosed with breast cancer, we are encouraging them to get the screening done. So that's an opportunity. There is no known or a structured screening program. Accessibility, we know that the number of cancer centers India actually needs is close to about, on a minimum basis, 1,500 cancer centers are required to treat every individual. If tomorrow every cancer patient decides to show up in a hospital in India, there is no space, there is no capacity to look after them. And the capacity at this point in time is just about, at best, about 40%, less than 50%, I would say. So overnight, we need a large number of cancer centers to come up, which wouldn't happen as we understand that. And of course, the distance traveled by an individual living in the villages and remote areas is long to go to a cancer center, get treated, and follow up the cancer out there. The second is the accessibility to the modern treatments and modern radiation, modern drugs. I think that also is a huge discrepancy because our financial spread is such that everybody doesn't have. But here I must say that there are so many schemes, Government of India schemes. The state governments are rolling out schemes where anti-cancer drugs are getting free, the basic drugs to treat cancers. And it's a good news that even today, some of the modern drugs, monoclonal antibodies and targeted drugs, oral injectables are being rolled out through these schemes. So it's a big step forward. So that's laudable, actually. That's really commendable. And I hope things only get better in the coming years. But we desperately need more manpower, more oncologists to be trained in this country. We need more cancer centers. Though we know that the private sector is taking a lot of lead in establishing centers in the tier 2, tier 3 cities. And that's, again, a very encouraging part. But that doesn't satisfy our needs, number one. And that's not the end of the story. It's just the beginning of the story, I must say. So a lot has happened. A lot more needs to be done. That's probably, I would summarize.
Thank you so much, sir. Thank you so much for so strong points, for putting out the word very nicely. We would also want to know another thing, that while we are working towards promoting early detection to larger population from earlier age groups as well, as you suggested, breast cancer is being detected in younger women every year. So what are the key strategies that you feel are very much important that the government as well as the private healthcare facilities needs to focus on for promoting early detection to a wider range of people? How can that be achieved, and how can initiatives how can we have more initiatives which are supporting this entire mission?
So there are many of them, and whatever I enumerate may not be an exhaustive list or may not be a complete list, and this is just top of the head. There is no structured sort of a list with me to dwell on. But first and foremost is the awareness of the disease. We are diagnosing a large number of cancer patients, but our dissemination of the information to the masses is not as robust. Let's go back in the late 90s when HIV/AIDS became a real menace. What happened? The government stepped in, media stepped in, everybody collaborated, and we were doing all sorts of activities in the print media, electronic media, everywhere, And when the world thought that this might overcome or overrun the population, it never happened. Why? Because there was a concerted effort. And the key point was the dissemination about the information that what are the steps to be taken to avoid the spread of this disease. So that type of a concerted effort, India needs to bring in. That there has to be some protected time in the print media or on the electronic media where dissemination of information about the early warning signs, how to prevent, all that must happen. Number two is tobacco. 40% of the cancers are linked to tobacco. So there has to be a concerted effort. We cannot ban it overnight because the farmers who subsist on that, we just can't deprive them overnight of their livelihood. India is a signatory to many international fora where India is committed that we would move towards a no tobacco regime, but that has to be defined. Let it be 2050. We don't mind that. But in the next 25 years, we work to achieve that. And then there has to be a downstream and upstream activity. Downstream, I mean that the consumer, we are raising the taxes. We are raising awareness. Good. A lot has happened on that front. But there has to be on the other side as well. The farmers need to be educated. They need to be given alternatives to those crops. And of course, they need to be given a timetable in the next 10 to 15 years, you transit from tobacco to some other crops. So that is a very, very pertinent point. Tobacco control is one of the big points. Look at these little, all these pouches, which are, one can put a dozen of them in the pocket and consume the whole day. And that's what is bringing us the problem about the head and neck cancers, oral cavity, tongue, and all that. So there has to be, again, an education of the masses. We see these advertisements on the print electronic media, very impressive, and which talk about the tobacco menace. That's one. Awareness, number two. Of course, the insurance companies need to be brought in. Because today, if someone decides that I have to walk into the hospital and get screened for cancer, there is no insurance reimbursement. I think that regime also has to change. The concept and the products which they sell also need to be redefined and so that it becomes more accessible. At least in the state capitals, in the metropolitan cities, so many cities, and then all these where the facilities for the screening exist, one could take care of that. The fourth is, of course, more centers, as I have alluded to in my previous answer, that we need more centers to tackle these cases. And of course, the cervical cancer vaccine. The world has shown that it works. It prevents cervical cancer. And imagine our eastern neighbors are at par with the Western world in the incidence rate, and then we are lagging behind. Again, screening so effective, vaccination so effective for cervical cancer. So the 3 or 4 major cancers, let's list them out. Breast cancer, again, screenable. Lung cancer, preventable. Head and neck cancers, preventable. Cervical cancer, vaccination and screening. So the top 4 cancers in India are amenable to some sort of an intervention. It can get better than that.
Thank you so much, sir. And it was really encouraging to hear you just list down everything in such precise detail. But at the same time, all these cancers that you have listed, the top 4 cancers, and rightly said, are preventable. But India is still suffering from these top 4 cancers, and majority of the people who do acquire cancer, it is one of these 4. Also, when we talk about breast cancer, there is this innate fear amongst the women and the entire community. Whenever they hear the word cancer, the fear creeps into them. And even if they feel a lump or something, just because of sheer fear, they do not reach out to their healthcare specialist on time or an oncologist to get it screened on time. Maybe hence that's why we see so many women arriving at at late stages of cancer, not at the early stages, because breast cancer personally affects not only the physical aspect, but also the emotional and psychological aspects of the women as well. So can you please touch upon this aspect, and how can we generate more awareness or different efforts that we can do so that this fear around this word can, be mitigated, so that people feel more open to come out and discuss?
So that's a very pertinent issue that someone who's diagnosed with a or detects a lumps on her own, there is an anxiety. But the key message which must go out to women across this country is that not all lumps in the breast are cancers. Majority of the lumps in the breast are non-cancers. And then when we talk about the education and the awareness, I think this is a key point which should go to the masses, to all the women in the country, that not all lumps are cancerous. And if there is a lump, then how would we get to know whether this is cancer or not? Only if you go to the doctor, get tested. And if majority are going to be non-cancerous, then the probability of a woman walking into the hospital with a lump is that it will be non-cancerous. But indeed, if it is cancer, then you have detected it at an early stage. Imagine the cure rate for stage 1 and stage 2 is absolutely, upward of, depending upon some of the subtypes, because breast cancer is not a single disease. It's a group of diseases based on the pathology and the molecular markers. But still, the cure rate is so high for early disease. And as you very rightly pointed, that a lot of our women, majority, are still getting detected in a late stage. That's on account of the fact that women do not divulge that lump to any of the family members, or do not come forward to say that I need help, medical help. But the key message is all lumps are not cancer. Majority are non-cancer. And only if you test would you get to know that you have a non-cancerous or a cancerous. And if you detect a cancer, then you have detected the cancer at a very early stage. Early stage means lesser treatment. You don't need to remove the breast completely. There is no disfigurement. And even if you need some radiation or chemotherapy, that may not be as intensive. Therefore, the smaller amount of treatment, bigger gain. And if you detect it in a late stage, then you need a lot of treatment, time consuming, finance consuming, emotionally, physically more draining, and the outcome is not as good.
Thank you so much, sir, for so nicely, putting out these points. Sir, another aspect that we were wondering about is, as you rightly said, that early detection is very important. We have been hearing that. And as you mentioned, that women are getting detected of breast cancer in their early 30s, starting from 30s even, now that we are seeing. And if we are screening, doing preventive screenings for breast cancer or breast lumps as well amongst majority of women, we can reduce the number of breast cancers to a larger extent. But sir, having a country such as India with such high number of population, how can we ensure that these preventive screenings for starting from a very early age, such as 30s, would be possible? How practical that is? Do you see any roadblocks being a major roadblocks in this process?
Another excellent point. The first and foremost is the benefit of screening. If you look at the Western world, the mortality from breast cancer is going down. And that has gone down only because of aggressive screening, awareness. Women are walking into the clinics with very small lumps. And their average lump size, which an oncologist sees, is less than 2 centimeters. And our average lump size is much more than 2 centimeters. That means our women are not coming forth to get tested and get treated. That is one. And the second part is that the bigger challenge is how to screen, and such a large population. Now, screening guidelines have been put forth by ICMR, by the Western world, and there have been, it's like a moving target. sometimes the age is 40 and sometimes the 50, but it's since we are about 10 years ahead of the Western world in most of the disease parameters. So our screening probably after about 40 makes sense. And depending upon the family history, if there is a family history, strong family history, or if someone is carrying that familial gene, which is the BRCA1 and 2, then the screening must start earlier. And then that screening paradigm is a little different from the screening of women in the community, because those who carry this gene or there is a high family history, the probability of getting breast cancer is more than an average woman. So therefore, the doctors would advise probably different type of a screening protocol. So that's a very small percentage of patients, but the majority, as you said, how do we screen them? It's a huge challenge in a country where we are still battling a lot of things at the primary healthcare level and the secondary healthcare level. So prevention of cancer is something which is a huge challenge, but then it must start somewhere. We can't say that only the day we would get better and we would have the resources, we would start. We can't do that. And it could start as a pilot on a government initiative, on a private public partnership, bring in these CSIR funds, bring in something innovative thinking, and then it could start as a pilot from one part of the country. Let's take up about 20 districts or 30 districts in different parts of the country and start doing it. And probably that would be my take on that. Begin small, begin steady, enlarge it, it will only get better.
Definitely, sir. Thank you so much. Very rightly pointed out that we must begin somewhere. We cannot have this, target of completing the entire NCDs, completely eradicating them from the country, and then focusing on cancer. That would be very late by then. So, sir, when we look at the, epidemiological graphs of the country going forward, there is seen to be a larger number of people getting into the older age groups compared to the younger age groups. Right now, as we say, India has already started going into the older age groups. So how do you see this oncology, affecting the older age groups that we will, have in the country, the majority of the older age groups? Would this have some sort of impacts on the oncology landscape? Or do you feel that, there won't be much difference? It will be just like this, how it is? What are your thoughts?
So let me take you down give you some trivia, and I think people are going to be impressed by this trivia. There was a health survey, the only single health survey done by the British in pre-independence, 1931. And out of the top 10 diseases, cancer was not one amongst them. So what has happened in the last, say, 100 years, close to 100 years now? From where has cancer suddenly come up, and especially in the last 30, 40 years? At 1947, when we got independence, the average life expectancy was less than 40 years. So people were not living long enough to get many diseases. They were only living enough to get malaria, typhoid, cholera, smallpox, and they were perishing because of that. Now people started living longer. Number one. Number two, our lifestyles changed. We became, more urbanization, and diets changed, less exercise. So the NCDs started creeping in, and cancer also, because cancer is partly, it is not entirely, partly a disease of aging. Only if somebody lives long enough, there is a probability of getting cancer. So if somebody was living just 40 years at one point in time, and now the average life expectancy is 70 plus, so the probability of getting cancer is higher. And that's a very pertinent point. So we need to make a beginning somewhere. Look at this population, the senior citizens, and then their probability of getting cancer. So we will need many more facilities. So lifestyles, aging, all these things are coming in. And apart from the cardiac, diabetes, hypertension, CKD, and the joint problems, cancer is going to be one amongst those list of the issues. And then we really need to strategize. So no doubt about that.
Thank you so much, sir. And definitely very rightly pointed out that it is not just the citizens that have to act fast when it comes to cancer care, but also the authorities and the government also have to, take this thing into account that we just discussed. Sir, another aspect that we wanted to know from you is that one of the major concerns when it comes to breast cancer and women is the fear of them feeling that if I go get the treatment done, my breasts would be removed. So they are not really aware about the conservative breast cancer treatments and the latest therapies that are available there. So can you please help us, put the word out there to the, latest advances in the treatments?
I can see Harith has joined, and then none other than him to comment on the surgical aspect. Harith, are you there? Okay. So anyway, so let me take that. So as I pointed out earlier, if the lump size is small, then obviously the surgery has to be small. For a small lump size, nobody is going to remove the entire breast. So breast conservation is the rule. Every physician would like to conserve the breast in a small lump size. But if the lump size is a little bigger, or there are certain other factors, then in today's time, we resort to giving some drugs, shrinking the lump, and then going in for a conservative surgery. We don't need to remove the entire breast. So majority women in today's time can go for a conservative surgery and not for total removal. Total removal is warranted only where the cancer has actually grown big enough, or there are big lymph nodes in the armpit, which are all, or the cancer is getting into the skin. All these factors actually denote that we are late in detecting. So early detection, lesser treatment, smaller surgery, no disfigurement, no cosmetic issues, and the outcomes are much better, as I alluded to earlier.
Thank you so much, sir. Before we part with you, your key takeaway message as we are commemorating the Breast Cancer Awareness Month this month, what would be your key takeaway message for the audience that is watching?
So it's a fear of delay. It's a fear of late diagnosis, which is the oncologists are worried. Because patients are walking into the clinics with late diagnosis. So don't fear cancer. Go to the physician early enough. Get yourself self-tested. And then indeed, if there is a problem, and if it is early enough, the solutions are robust. The outcomes are not as mutilating. The overall outcome, survival from an early disease is excellent in today's time. So get tested. Be breast aware. What we say that women should do a breast self-examination, and in case of any suspicion, I think they should go to the physician. So be breast aware. Any abnormality, go to the physician, go to the doctor, and get yourself tested. That's the best way to go about, and that's our insurance for a better outcome. And take care of your lifestyles, actually, and exercise, body weight optimization. That will not only give you protection against cancer, also protection against diabetes, heart disease, joint problems, all these things. And then, of course, shun tobacco. No tobacco is safe. Thank you so much.
Thank you so much, Dr. Ashok Kumar Vaid, Chairman, Medical and Hemato-Oncology Cancer Institute, Medanta. Thank you so much for taking out time from your busy schedule, imparting us with wealth of knowledge and information. We also had Dr. Sushmita Rath, consultant medical oncologist at Tata Memorial Center with us before we were discussing with her different aspects of this topic that we were discussing, unveiling the breast cancer landscape in India. I would like to thank all our panelists for taking time, for imparting wealth of knowledge and information in this episode. Thank you so much.
Thank you so much. Namaste.
Thank you, sir. We will be followed by another panel after this, which is on a different topic around breast cancer again. It is on the topic of advancing breast care therapies, innovations in research and development, and we will be starting that shortly. With that, I would like to inform the audience to stay tuned so that we can start with the second episode in few minutes. Thank you so much. Hello and welcome to one and all. Good afternoon, everybody. I welcome you all to another episode of the Breast Cancer Action Month Summit. This is an initiative of Integrated Health and Wellbeing Council and Rapid Global Cancer Alliance and being powered by Novartis. So for today's discussion, we would be discussing on another aspect of breast cancer as we are commemorating the Breast Cancer Month, Awareness Month. So the topic of this discussion is advancing breast cancer therapies, innovations in research and development. And this episode is the second episode we had today. The first one was on the topic of unveiling the breast cancer landscape in India. So for this episode, we have an eminent set of panelists here with us today. I welcome Dr. Harit Chaturvedi, Chairman, Max Institute of Cancer Care, for joining us. Thank you so much. I welcome Dr. Anant Bhan, researcher in global health. He's here with us today. We would also be joined by Dr. Shona Nag, Director of Oncology and Senior Consultant of Medical Oncologist at Shahadri Hospital, Pune. She would be joining us shortly. We would also be joined by Dr. Anita Ramesh, Senior Consultant, Medical and Pediatric Oncology at Apollo Specialty Hospitals and HCG Center, Chennai. With that, we will be starting our discussion. My first question is to Dr. Harit. Sir, we would very much like your opinions on basically the landscape around innovations that are there in research and development around breast cancer therapies, and according to you, what are some of the therapies in clinical settings that are helping in fulfilling the gaps that we have been facing in the previous years around breast cancer challenges? Over to you.
So thank you, Imani, for having me, and thank you for doing this, because I think one of the most precious weapons we have is the awareness and the ability to pick cancer early. If we can do this awareness very well and improve the hope in the minds of people, that will be a great thing, and that is what our endeavor should be in all these things. So, see, if we look at the evolving landscape, everything has changed in last. Every aspect has changed. The understanding of how the cancer happens, the application from diagnostic area, the understanding of tumor biology. So, and then comes the therapeutic part. Every aspect has evolved in a major way, and I think in last 25 years we have seen significant improvement in survivals, significant improvement in picking cancer early. If we look at the average tumor size which we see in our clinics today, it has gone down significantly, and that is thanks to programs like this, which sensitize women to report to their doctors early, and also the overall ability for the doctor fraternity or medical fraternity to connect and make sure that the patients land at the right place for a workup. So if it is imaging, the use of mammography and ultrasound has gone up, but significant impact has been of the MR also as a problem-solving tool, because we know that mammogram can miss a good 1/4 of these cancers. While in digital mammography and 3D it is possible to make it better, and now we see also the contrast enhanced ultrasound and mammogram that's also improving the ability of making a early diagnosis. But MR should be used as much as we can for whenever there's a doubt, and that is one area where we see impact on our practice and in our outcomes also in cancer detection. Then we come to the pathology bit, the guided biopsies. So I hope it is in sync with what is your focus.
Yes, sir. Yes, sir.
I would talk about things which rarely we see in the clinic which have changed. So earlier we used to have these blind biopsies. The clinicians would do a sampling by palpation, but now it is a gold standard that you do a guided biopsy. So ultrasound guided biopsy is very important. Your pickup rate has gone up. You're taking of the sample from the right place is very important. And these things, see, once you have a wrong diagnosis or something you have been labeled as benign, in that case, the patient gets comfortable and gets casual, and the whole thing gets delayed by 3 to 6 months. Because then they will fall back on this report that, okay, the biopsy said no cancer, and so there's nothing to worry. Therefore, it is very important the biopsy is done the right way, the imaging has been done the right way, and we are sure that we have a definitive diagnosis, whether cancer or not cancer. Those things are very important. And once you have a diagnosis of cancer, then what kind of cancer are we dealing with? Has to be known upfront, whether it's a triple negative, HER2 positive, or luminal A, luminal B type. All this is very important to understand. And once we have that identity creation, that what kind of tumor it is, look at the stage of tumor. For example, the primary tumor, the axillary nodes, and any metastatic workup required. What is it say? Those things. So I would say come a long way.
Sir, I believe we are losing your audio over there because of a network issue. Yes, but we were able to understand what you highlighted. I will come back to you with few more questions. I will take the next question from Dr. Harit Chaturvedi. Sir, Dr. Anant Bhan. So, sir, being a researcher in global health, can you please enlighten us with some of the latest insights that you have been observing specifically for the, breast cancer in India? And can you please help us, compare and contrast the urban scenario with the rural scenario? Do these go commonly together, or do you see major drastic differences between the prevalence and the rates of breast cancer in the rural areas compared to the urban areas?
Thank you. Thanks for that question, and pleasure to be here today. So, I think this is an important topic for us to discuss, given both the burden, but also the importance of breast cancer to women's health. Already, I think this might have been iterated earlier in some of your sessions, but it's an important reminder that there are almost 2.3 million women diagnosed with breast cancer globally, and it's attributed that breast cancer causes around 685,000 deaths on an annual basis. At the end of 2020, there were already 7.8 million women alive who had been diagnosed with breast cancer in the previous 5 years, making it the world's most prevalent cancer. Now, interestingly, in India, more women are overall diagnosed with cancer as compared to men. And also ICMR data, the Indian Council of Medical Research data, indicates that cancer will likely afflict almost 1.57 million people in 2025, up from 1.46 million in 2022. Now, specifically within women's health, as we have already discussed, the top cancers are breast cancer, followed by cervix, ovarian, corpus uteri. And specifically for breast cancer, an AIMS estimate projects that breast cancer cases might reach up to 250,000 by 2030 in India. Currently, this number is somewhere in the 185,000 sort of broad estimate level. And the incidence rates likely usually increase around the early 30s and peak around 50 to 64 years. Now, coming back to your question around differences between rural and urban areas, I think the stressors, the risk factors, and the incidence is likely similar. What is different is the identification, the screening, the early identification, the linkage to care. As my fellow panelist was already indicating, that there is certainly more awareness around breast cancer now, and that perhaps would be seen more in urban areas because there is the likelihood of having access to information, and also access to health centers where you could go and get screened early, and if you have the disease, then of course being identified and put on care. That is lesser so in rural India, and while it has certainly increased than before, there is still a long way to go. And even within rural India, as you would understand, there are large pockets which are even further marginalized from a health system perspective. So in tribal parts of India, in very rural parts of India, that difference would be higher. And this points again to the fact that while we have a lot of innovations happening in this space, we will need to also keep striving to ensure that these kind of innovations also reach primary care. And so what can we do at the primary healthcare level? What can we do at our upgraded health and wellness centers in terms of both prevention, but also early identification of women with symptoms with breast cancer, and then linking them to care. So that I think is an extremely important thing. Thank you.
Thank you so much, Dr. Anand. We'll take the following question from Dr. Harit. So, sir, as Dr. Anand has been mentioning that, it is very important to focus on the prevention as well as early diagnosis. Where do you feel that how can how can multidisciplinary collaborations come into this in breast cancer treatment, early detection and care? And can you please highlight any successful collaborative efforts or approaches that you have witnessed or been a part of that you feel that can be translated to more hospitals and more healthcare facilities to get our purpose and aim solved?
So I think Dr. Anand brought out a very valuable point that it is not just the advancements, the access also which is important, and which is we see huge disparities across our country in different segments and societies. So we won't be able to back up. I won't be able to back up with data that how our collaborations make a difference. But as oncologist, I try to reach out on every opportunity to send the message out that early detection is not something which is screening is a big challenge, but early detection is something which is possible with all our with the clinicians themselves, the general practitioners, the gynecologists, the primary care physicians, wherever it is possible to interact and create an interface. Just by knowing that having a systematic approach to problem solving, we can actually come to early detection and diagnosis of cancer. So collaboration-wise, we do these projects and different things with Rotary, with different NGOs and segments. But I don't have data to say that how the screening or this education has impacted the outcome. What we do see in our clinics that probably today the stage 1 and 2 presentations is somewhere in the range of 30-35%, which used to be less than 20%, maybe 15 years back. So this is probably because of the collective awareness, and also today the women themselves, not just the clinicians, the women themselves are quite aware that they have to react to or act on any new finding in the breast, and that's not screening, but that helps in early detection. And as far as the prevalence, the prevention part is concerned, it's very important to realize that it is a huge lifestyle disease today, not just breast cancer, cancer as a whole. Almost 50% of cancer can be prevented just by improving the lifestyle, whether it is tobacco, alcohol, obesity, lack of exercise, or inappropriate food which we take, or high fat content in our diet. If we just pitch that awareness, make sure that the schools and the adolescent age group is aware of this, because that is where the change is possible and impactful change is possible. So that itself will lead to prevention. And I think the knowledge is percolating, the awareness is coming, and therefore I'm quite hopeful that this will have gradual impact.
Thank you so much, Dr. Harit. We have Dr. Anita Ramesh who's joined us. I would like to take the next question from you, ma'am. The question that we would want to know from you is, how can we work towards improving patient outcomes? Because when it comes to breast cancer, there are a lot of things, not just breast cancer, but cancer as a whole as well. There are a lot of things, not just in terms of physical care, but also emotional and psychological support that the patients require, the women require who experience breast cancer in their lifetime. So how can we better support such patients? What are some of the innovative, if there are any innovations in research and development around this, if you can highlight that you have been using or you have seen to have worked, get tremendous impacts on their overall emotional and psychological health. Dr. Anita, over to you. Okay, I believe ma'am is not able to hear us. I will get the team to help her on the back end regarding this. I would also take the same question to Dr. Anant Bhan. Sir, we would also want you to answer on the same point that, in cancer, it's not just this physical care aspect, but also the overall well-being that needs to be ensured. And how can we help, this care aspect to reach not just the urban health facilities, but as you said, you're reaching to the lower socioeconomic groups, reaching to the rural areas, reaching to the tribal areas. How can we, if there are any roadblocks in this process that you can see, in providing equity for cancer care?
Sure. So, I think as much as cancer care is about the treatment, it's also about ensuring that the woman feels supported, right? Because we will all recognize that there is stigma, there is shame around cancer, which is unfortunate. And that's part of what we all need to change, which is where programs like this become important. So when we talk about cancer care, and especially at the primary care level, I think we need to build systems which allow for women to feel supported, right? Because one of the challenges is often in rural areas, late reporting. So if we can have a culture where they are, supported to come to health centers for regular screening, right? And this can be not just for breast cancer, but also cervical cancer, oral cancers, other forms of cancer, which are quite common in women. Now, fortunately, a lot of our frontline clinics, health and wellness centers, primary health centers, are often having women health professionals. These could be ASHAs, A&Ms, screening nurses. Many community health officers are also women. And so that could perhaps also culturally build more comfort, right? So if we could encourage women to come regularly, and not just for maternal and child health care, if they could be asked to come on, let's say, an annual basis to have a conversation around their health needs, including on breast self-examination, if there is a need for any symptom checks, etc., to be done. And that is where information can be shared, but they could also be put through a comprehensive checkup of their health, which would include breast care as well. And that would help hence, because then women would understand that this is something which is important and that they should be doing it on a regular basis. And this would help in early identification. Also with new forms of communication being available. Fortunately, the one among the few things which happened in the pandemic, which are positives, was telemedicine, right? There is now more and more availability of telemedicine. So if, for example, CHOs or medical officers have a suspicion and they need a specialist input, if rather than referring women to go to the district center or a tertiary center, they could also use telemedicine to consult with a specialist. and get at least early advice to be given, right? And that could help again in early identification and linkage to care. Only those women who hence then need to be referred up the chain can be asked to go to the district center or to the tertiary care center. So I think there is certainly a lot of innovation which can be done in the primary care spaces as well, but certainly more conversation around women's health and breast health is extremely important, and hopefully that will mean that we'll have some transformation happen. Thank you.
Thank you so much, sir. We will come back to you on different aspects shortly. One of the questions that I would want to know from Dr. Harit is, sir, in your opinion, how do you envision the future of breast cancer treatment or cancer care and treatment? And what role do you see, leading institutions such as Max Institute, other hospitals, as well as other, organizations being a part in leading the new era of advancements and change in and awareness in care and cancer care equity? So what would be the next step to be like right now?
What we are, so what we are already seeing, Dr. Savri, is that there is a lot of new trial studies happening for screening purpose, and there are tools being evaluated for mass screening by blood sample and identifying the high risk group and ensuring that these high risk groups get appropriately screened by simple methods where less false negatives and there's no possibility of false positive. So as we improve these screening tools, probably that will be one big breakthrough, which will give us an opportunity to detect those people at high risk and also provide them appropriate treatment at an early on time, which can give us much better survival. Likewise, innovation is happening in every front, as we discussed, and a lot of end of the day, we are looking at opportunities how to improve the survivals and the quality of life. These are the two key issues which are in everybody's mind. And whether it is for surgery, already we know that how sentinel node and all these things have changed the incidence of lymphedema, and the breast conservation rates have gone up, even in looking at advanced breast cancer. So we know that the whole focus is improving quality life and quality of life both. And whether it is a surgical field or in the medical field, from the era of application of hormone therapy to combination drugs, which have given even better results, we are seeing all that transformation, improving the possibility of survival and cure rates. Now, even in I would say, today's era of metastatic setting, where we know that low volume metastatic disease has very good cure rates and survivals, and oligometastatic disease is categorized separately with aggressive treatment approach. So we have to see how these things are shaping up and evolving. So one will be quality of care, the other is access of care. Both these spectrum for a country like ours has to be addressed in totality. And as I see the future unfold, I'm quite hopeful that we'll have very good results, and large majority will picked up in early stages, or even for that matter, prevented from cancer. We don't have to go through the numbers as we see in the Western world just because of growing economy. By better education and awareness, we can actually address the problem of health related to lifestyle and improve the incidence or bring it down.
Thank you so much, sir. We have Dr. Shona Nag here with us.
I will take leave, Savri. I have to leave for something.
Sure, sir.
Thank you for having me.
Thank you so much for joining.
Thank you.
So we have Dr. Shona Nag here with us, who is the Director of Oncology and Senior Consultant Medical Oncologist with Sahyadri Hospital, Pune. Ma'am, thank you so much for taking out time.
Not at all. Not at all.
For this awareness discussion. So, ma'am, we are as we are commemorating the Breast Cancer Awareness Month, we are talking about different aspects and raising awareness around breast cancer amongst the audience. This panel discussion is on the topic of advancing breast cancer therapies and innovations in research and development that are happening around breast cancer. So, ma'am, as the topic is around these advancements, in your opinion, in your practice, how have you, experienced any emergent latest, breast cancer related therapies or technologies that you feel, would be, in future would have great impacts or are already showing great impacts in the lives of women that you are treating?
So while I say that the parts of the world like the US and the West and other countries, there's been a lot of research in this field, and it's been a tremendous journey in the last 25, 30 years to watch the transformation in the care of breast cancer. So the drugs that are available are amazing. As Dr. Harit alluded to, that even in stage 4, patients are living for 5 years and 8 years with a very good quality of life. But our struggle in India is like, we are a country of contrasts. We step into a 5-star, few hundred meters away is a slum. So this is a country of contrast. There is a lot of inequality still. And even living in Bombay, you have some people that have access to the very best, and you have people that don't have access at all. And this is going to be the major challenge in getting those innovations that we are going to talk about, the different drugs, whether it's, things like sentinel node in surgery, whether it's advanced radiotherapy techniques across all the tier 1, 2, 3 cities, and having at the same time screening programs that will pick up this disease early, whereby we can cure it. I mean, no oncologist likes to pick up advanced breast cancer, honestly, because we know the cure rates are already compromised. Nobody wants to diagnose cancer in stage 4, or nobody wants it to progress to stage 4. But for that, we need early diagnosis. And our population is so huge that it belies a very good screening program. There are a lot of limitations in screening. Women are not aware. So I think programs such as yours, and maybe more programs for the lay public, will really help in awareness. The first step is awareness. I have a problem, whether I have a problem or not, come in for regular checkups. Women don't take care of themselves here. So early diagnosis is still very important. It is not happening in our country. Can you imagine the benefits of an early diagnosis with the innovations? Cure rates will go through the roof. Right now, we are losing. So if I say 1.7 lakh new women are being diagnosed with breast cancer every year in India today, 85,000 are dying from breast cancer. So the mortality rate is 50%. Now, if I give you a comparison in the US, there's much more breast cancer. Say there is 3 lakh women or 4 lakh women being diagnosed every year, but only 20% of those are dying. So that is the ratio we are looking to, bridge with newer and newer treatments. But like I said, most important, early diagnosis and coming in where we catch you before you feel the lump. That's very, very important. And as far as the innovations go, earlier we used to treat breast cancer as one disease. Today, we don't treat it as one. We treat it as different diseases depending on the estrogen, progesterone receptor, and the HER2 receptor. And I must say, it's been fantastic to watch targeted therapy evolve in the HER2 positive subgroup. It's been amazing to see antibodies and now antibody drug conjugates, which are nothing but, like an antibody is like a vaccine. It has that Y-shaped structure. So what we are able to do is now to tag the chemo onto that Y-shaped structure. So the Y-shaped structure antibody enters the tumor cell and releases the chemo inside the cell. I mean, that is technology and precision medicine at its best. So while we are looking at these drugs, first in the later setting, stage 4 setting, and now they've been moved into this early stage setting, we hope to gain a lot more cure with these newer drugs. All are not available in India, but I'm happy to say a lot of these drugs they're reaching us. We are very clever with biosimilars and generics, and it's a matter of time before this treatment becomes affordable to the Indian population. So there is a lot of hope to look forward to, but my basic contention is, why wait till a stage 3 and 4? Get the cancer when it's completely curable, 90%, 85%. These are good numbers to work with. And India needs to develop a good screening program for that.
Thank you so much, ma'am. So we have Dr. Anita Ramesh as well here with us, who's the Senior Consultant, Medical and Pediatric Oncology of Apollo Specialty Hospitals and SCG Cancer Center, Chennai. Dr. Anita, ma'am, do we have you with us? Ma'am, we are not able to hear you. So Can you please unmute and respond if you're there? Okay. Dr. Anita, are you able to hear us? Okay, I believe ma'am is not able to hear us. I will move on the following question to Dr. Anant Bhan. So, sir, as ma'am, Dr. Shona ma'am highlighted that it's not just the urban and rural population divide. It is also that in urban cities there is both, financially well and financially, marginalized population both. So, how do we account to the research that is available around breast cancer specifically, of people living economically less, if people of low socioeconomic backgrounds living in urban cities and the prevalence of breast cancer amongst them. Do these, prevalences vary greatly from the people of high socioeconomic backgrounds living in urban cities? Dr. Anant? Yes.
Yeah, thank you for the question. So, listen, I think cancer is a condition which democratizes, in the sense that it afflicts everyone, right? Every section of the society. So the risk factors, of course, could differ, and that is something that we spoke about earlier as well. But it's important to remember that the likelihood that someone from a rural or a socioeconomically more vulnerable background might not be able to have the same access to early identification and linkage to care is certainly something which we all need to worry about. It's all the another important fact here is that healthcare access and expenditure on that, especially out-of-pocket expenditure, is a leading cause of indebtedness, especially in rural India, right? And that points again to the fact that we need to ensure that the innovations that we speak about are also available for those who are in the relatively lower socioeconomic bracket. That will, of course, mean that public hospitals, for example, should also have these innovations being available, that we should have early identification, screening, linkage to care, availability of therapies, including the newer therapies that we've been discussing. These should be also available in public hospitals, because in the absence of that, it might be difficult for someone with cancer who's coming from a relatively poorer background to be able to access these therapies. The other component, of course, is insurance. If our insurance systems, whether that be in the public space like Ayushman Bharat, or the private insurance space, where or insurance through mechanisms such as the ESI hospital mechanism, all of these should be able to cover therapies, including newer therapies, which we know are likely to be more beneficial. It's also possible to do innovations and research in primary care spaces to try to find out what do we know so far about breast cancer therapy, and how do we ensure that this is available at an early stage in an affordable manner. And this is where I think the role of Indian pharmaceutical players becomes important, because as they are an important source of generic production, similarly in this space, in the cancer spaces and also the breast cancer space, if they could help bring down the costs of medication and therapy, then that would be really useful in ensuring that no one is devoid of care for breast cancer, and the cost of therapy should not become a barrier to women being able to access that income.
So there is another question that we would want from you, from a research perspective. What areas in breast cancer therapies do you feel hold the most potential for further advancements? And another aspect, which is cancer in the rural population and the tribal population, are the risk factors vary very drastically from those of the urban population? What has been your observance?
It's likely that the risk factors are similar, but of course, in an urban setting, there could be more risk factors related to, for example, lifestyle, right, and food, etc. In rural area, it could be more linked to the fact that it just gets identified later. And we also certainly need to do more research in trying to understand in rural and tribal parts of India what might be other specific risk factors, because it's likely that there might be a whole bunch of things that we have not yet looked at in comprehensive detail. I think globally now there is a lot of focus on trying to do a more comprehensive risk-based screening, which can pick up bases, for example, the women's genetic makeup, the family history, other risk factors around nutrition, etc. Whether she has been pregnant or not, or whether she has had childbirth or not, etc. And then have also linkage to interventions for then using all of these scores to be able to come up with some kind of a composite risk score. Also, of course, you could have regular screening happening through mammographies, etc. Ultrasound is being used, but not all of this could be always available in the periphery. So we have to try to figure out how we can, like in the cervical cancer space, now there's been a lot of movement towards at least trying to make visual inspection with acetic acid available, because that is something a peripheral health worker can do. So here also, at least if self-examination is something which can be promoted, guided examination is something which can be promoted, and peripheral health workers, especially women health workers, can be encouraged to support women, make them feel comfortable, and at least that kind of screening is happening, so that again, basis that women could be then linked up to further screening and early identification of care. So I think that's certainly one area. There is a lot of work certainly happening also in the precision care, especially in oncology, where you have personalized medicine being offered, because of course, within breast cancer, you have cancer types which are responsive to certain types of therapies much better, they're hormone responsive or not, etc. So if we are also able to identify women and know what kind of therapy is likely going to work best for them, then they can be put on that therapy early, and that increases the chance that we will be able to provide a better quality of care and something which works better for them. So again, all on the screening side, on the linkage to care side, as well as on the therapy side, in all of these, you can have a lot of innovation happening. And we need to contextualize what of these might be possible to offer, let's say, in a peripheral health clinic, versus what of this needs to be available in a public hospital, what of this might only be available in a tertiary care center, and then how do we ensure that that is not only available to those who have the possibility of paying for it, but is also available to those who might not be able to pay for it because it's more expensive, but then there are supportive mechanisms through, for example, government support to enable access to them. Over.
Thank you so much, sir. My next question is to Dr. Shona. Dr. Anita, are you able to hear us, ma'am? Because we feel you're not able to hear us. I'm trying to ask questions to Dr. Anita, but I'm not able to get any response. Anyway, moving forward, I have one question for Dr. Shona, ma'am. So as you have been highlighting that, screening to women from early on can solve a lot of, aspects around early detection, around breast cancer. But having, in a country like India, where the population is so large, we are already facing so many issues preventing the already, other forms of diseases. Preventive screening to women from early ages, how practical do you feel that is? And what would be your suggestions on how can, public-private partnerships come here and help us, bridge that gap that we face?
So I think that's an excellent question and very important. All of us in our own private way, we do a lot of corporate talks, awareness talks to women in different age groups, but it's happening at a very micro level. I think if the government took it up, like our previous speaker talked about self-breast exam, the idea of self-breast exam starts at 20. All right, not when the woman is 45, 50. And the purpose of self-breast exam is not to diagnose and say, I have breast cancer and come to the doctor. The idea of a self-breast exam is to know the nature and feel of your own breasts. Now, this is a taboo, social taboo. Women are shy, but we have to overcome this to save lives. So I think you need the social workers, as he rightly said, we have even trained ASHA workers through our foundation, and we found them, to be very, very useful with breast models, where we've actually made a breast model and put little balls of different size to mimic different tumor sizes. But this needs to be done on a war footing. Then when we talk of clinical breast exam, every primary health center doctor, every secondary health center, so even in the smaller towns, villages, tertiary, third tier cities, second tier cities, there should be an awareness, and gynecologists and surgeons and maybe even some MBBS people will need to undergo a basic training program of clinical breast exam and when to refer, because yes, mammography is not possible at our population level. It's just too expensive, it is not cost effective, and we can't reach everybody. All right, there's too much of technology involved, and it becomes a self-defeating technology. Although having said that, people do mobile mammos and go, but that's just a one-off thing, so even if we can't do screening every year, do it every 2 to 3 years in the Indian population and look for innovative methods. Now, there is thermal screening, but that doesn't work in a hot country because a woman's temperature has to be on the lower side to be able to pick up something abnormal. We did a recent study of 100 office people. Do you know, we were putting them in cars in the AC so that their temperature came below a different level so we could pick up something on thermal screening, and we compared these thermal screening films to mammos later. So we did a direct head-on-head, and it was a miserable thing. Second thing is the eye breast. The government is promoting eye breast. Again, things go wrong at that level. There are too many false positives. These women then don't come for a follow-up when they're told to have a mammo. So I don't know the right answers, but there has to be a cheap, reproducible method. We are actually working on a trial with a company in the South where this lady who's a scientist has come up with breath analyzer. And she's done it in 100 of our patients, 50 normal, 50 breast cancer, early, not treated. And she's found 3 volatile compounds in the breath of the cancer patients. And now that prototype is ready and we are taking it to the next level. So a test like that, which is cheap, which nobody minds, using a breathalyzer. And it doesn't cost much, it's easy to read. So something like that would work, but then it needs to be validated and tested. So somebody from IIT or somebody has to come up from the public-private partnership, like you said, and come up with an innovative method for.
Okay, I believe Dr. Shona made her point very clear, and I believe there was some network error on her end that she logged out. Yes, I think we have her back. Yes, ma'am. Are you able to hear us? Yes. You're on mute, ma'am.
So yeah, I think that's what I wanted to say, that innovation is really, really required and we need to come up with something.
Yes. Thank you so much, ma'am, for the brilliant ideas and concepts that you shared. My next question is to Dr. Anant Bhan. So, sir, as we are discussing on the different, advances in breast cancer research and development, can you help us understand and track back a little bit? Because as, in the previous conversation, Dr. A.K. Ved shared with us that, so many years ago, the prevalence of breast cancer was not even existent in Indian population because the lifespan of the people was pretty less. But now that the lifespan has, increased with the help of modern medicine and advanced healthcare facilities, we are having people, more in the later age and thriving well. So how does the future India look like from epidemiologist and research point of view? What is what are the future trends in cancer care that the researchers predict? If you can help us understand that.
Sure, thanks. So I think with the advancing life expectancy and also issues around, let's say, increasing pollution, the lifestyle changes that we are seeing, food changes, etc., there's certainly going to be a whole lot of risk factors which could translate into a higher prevalence of cancer, including breast cancer. In fact, the estimates being put out both by global bodies as well as by Indian bodies indicate that the numbers will increase, and probably the risk of getting these kinds of cancers will also increase, which again points to the fact that you could work on reducing the risk factors. So more awareness, knowing what could be potential risk factors, especially because risk factors might be different also. For example, someone with a family history is likely someone who should be very regularly and assiduously checking in and getting an examination done themselves, as well as perhaps going in and for a clinical consult on a regular basis. Other folks who might be living in areas where there are certain other risk factors should be aware of that and try to minimize. But what is also important is hence to ensure that we are able to respond from a health system perspective, and having therapies available, having modalities for screening, for diagnosis, and also ensuring that anyone who is identified is then able to be linked to high quality care becomes crucial. Innovations can also be around trying to figure out what other culturally acceptable modalities could be there. I just read a few months ago a story which was put out in the BBC around, there is a whole bunch of visually disabled women in India who've been trained to do medical tactile examination. So they basically offer breast examination for others who need to be screened, and they've been trained to be able to pick up based on touch any changes that could be indicative, for example, of early stage breast cancer, etc. So again, if some of these things could also be deployed, because that could help us pick up any cases early enough, and that I think is an extremely important part of responding, that we need to find ways of early identification while also working on the risk factors. Thank you.
So when it comes to research around cancer space in India, do we have optimum research available with us, or do you feel that much more research is required, just like every other disease in the country? And are there any specific areas that you would like to advocate to have more research being looked into these aspects of cancer?
Sure, I think so. We are certainly doing good quality research. You have centers both in the public space and the private space, Tata Memorial, AIIMS, etc., who are doing some really good research studies. They're also collaborating with other institutions to build the data. There is also cancer registries, which have been very effective. ICMR has set up a cancer registry specifically to look into, also trying to understand what, from a public health data-based perspective, as to what kind of prevalence do we have, and what kind of distribution do we have of cancers across the country. So that I think needs to continue. We also need to do more in terms of identifying ways of encouraging women to come in for screening and making screening available, especially in the primary care scenario, and then being able to quickly diagnose and put women on therapy. And that's where innovation on the therapy side, in a way that it's more likely to be beneficial to them from a timely perspective. So personalized cancer care, for example, or cancer care where we have evidence to indicate that this could lead to better response. And also, I think another element which we don't often speak about is the fact that unfortunately there will be a segment of women with breast cancer who will not be able to be helped from a therapy perspective, right? So making palliative care available, end-of-life care available, comfort care available, and ensuring that we have those services and research on how to make those available, to anyone who needs it becomes important. Because what you don't want is a woman who perhaps is suffering unnecessarily because they have exhausted all forms of therapy, but then are going through a very, very painful situation at the end of their lives. So making good quality palliative care and end-of-life care available is also an important part of good quality breast cancer. So as much as we would, as clinicians, as public health folks, as folks who worry about breast cancer as an issue, not want to lose any woman. Unfortunately, there will be some women lost to cancer. But if we could ensure that this is as much less disruptive to them, it would be ideal as well. Thank you.
Thank you so much, sir. The last question from you for the session is, so sir, as we are talking about breast cancer, many people understand breast cancer to be happening only with women. They are completely unaware of the fact that breast cancer even occurs in males, and males having genetic history of breast cancer in their family also disposes them to have higher chances of, getting breast cancer. So, how are the studies like around breast cancer of males in India, and what is the current prevalence that we are seeing? Over to you, sir. Yes.
Yeah, so it's certainly that's an important point. I think it usually because of the perception that this is only a women's health issue, it sort of gets lost in terms of the also raising the importance of this being something to be aware of from a men's health perspective. And while the of course the rates and the prevalence is much lower, it is still an issue because some men will have breast cancer, and again the sooner it is identified and the sooner they are put on treatment, the more likelihood there is that this is something which can be addressed early enough. And like women's, breast cancer in women, if that is not done, then they could also have complications, including severe disease, death, etc. The numbers, I think, again, this is an area where more research is certainly warranted, but it's similar to global numbers in terms of it's certainly not being among the top cancers in men, but it is certainly one of the forms of cancer which men need to talk about, and especially in terms of gender diversity, sexual minorities, etc. Again, important to remember, for example, that this could be an issue among trans women, etc., who are also at risk, and again trying to understand what kind of risk factors, including genetic history, family history, as you rightly pointed out, would be useful to do that. But in terms of advocating, I think men also hence to need to be aware of signs, symptoms, and the need to reach out if they're seeing any changes which could be indicative of them potentially having breast cancer. So I think that is certainly an important part of making men aware about being conscious of this and reaching out to professionals if they are suspecting anything in this. Thank you.
Thank you so much, sir. With that, we come down to the end of our super insightful session for today. Just before we leave, we would like to have one key takeaway message from you to all the audience that is watching as we are commemorating the Breast Cancer Awareness Month.
Yeah, from my perspective, I think my main takeaway is one that everyone has a role to play. This is not just an issue for women to worry about. I think all of us should think about and find mechanisms to encourage more conversations around breast cancer, the need for breast cancer to be picked up early through screening, through early identification, through linkage to care, and ensuring that we are all focused on also innovations in this space so that we are able to address the rising numbers and ensure that high quality access to identification, treatment, therapy, and that being available across the country is ensured. So thank you again. I think this was an excellent program which has contributed to that cause.
Thank you so much, sir. Just checking in again, Dr. Anita, if we have you with us, as we're not able to, get in touch with you on the video or audio. Okay. With that, we would complete this session for today. Thank you so much to all the panelists for joining us. Thank you, Dr. Shona Nag, Dr. Harit Chaturvedi, Dr. Anant Bhan, Dr. Anita Ramesh for joining us on this session on the topic of advancing breast cancer therapies, innovations in research and development, an initiative of Integrated Health and Wellbeing Council along with Rapid Global Cancer Alliance and being powered by Novartis. Thank you so much. With that, we come down to the end of super insightful discussion. We would also like to thank our partner Novartis in this initiative for raising awareness around breast cancer. Stay tuned for more episodes on this series of Breast Cancer Action Month that we are doing to raise awareness around different topics of breast cancer. which would be following in the week coming along. So stay tuned for that. And I would also like to thank all our audience for staying with us till the very end. Thank you so much. With that, we sign off now. Stay happy, stay healthy, stay informed. Thank you so much.